Okay, sir. Good evening, everyone present here. I welcome all the participant doctor on today's session. Let's welcome today's speaker with great honor, none other than Dr. Mrinal Sarkar sir. Let me share some of the achievement of this sir. Sir has done MD, DRCD, EDIC, EDARM, Director and Head of Pulmonology and Critical Care at Fortis Hospital, Noida. And for today's session, the topic is current management of asthma. Before starting this session, let us know the overview of the topic. The current management of asthma focuses on personalized approach to control and prevent symptoms, improve lungs function, and enhance the patient quality of life. This includes a combination of medication, regular monitoring, lifestyle adjustment, and patient education to achieve optimal asthma control. In this session, the sir will discuss about assessment and diagnosis, medication and management, and individualized treatment plans. As sir will be joining us in any moment, I request all the participant doctors. If you have any questions related to this topic, you can just note it down and comment on the live streaming page. I once again welcome all the participant doctors on today's session. As for today's our guest speaker is Dr. Mrinal Sarkar sir. As sir is joining us in any moment, I request all the participants, if you have any question related to this topic, you can put it in the comment box.
Presentation share. खोल कर.
Hello sir, I welcome you on today's session. As I have already give your
Hello.
introduction about the topic, sir. Over to you, sir. You can proceed with this.
Are you able to see my presentation?
No, sir, you have to share the presentation from share screen from Zoom.
Yeah. Are you? Is it visible? Hello.
Yes, sir, it is visible on the full screen. You can proceed with the session. Over to you, sir.
Uh, Good afternoon, everyone. Sorry for usual technical glitches in the beginning. I'm going to be talking about asthma management today. The what are the current guidelines, etc. Uh, इसको minimize कर सकते हैं? इस वाले बार को. Yes. ठीक है. So asthma is a heterogeneous disease, usually characterized by chronic airway inflammation. This is the key to today's understanding of asthma, where most of us grew up thinking that asthma is something which was only associated with narrowing of the airways. The current understanding is it's a chronic airway inflammation. And the other characteristics are that all the symptoms, wheezing, shortness of breath, chest tightness, cough, vary over time and intensity, together with a variable expiratory flow limitation. The However, the airflow limitation or difficulty in the air to pass through the air tubes can later become persistent rather than variable later in the course of the disease. So worldwide, approximately 260 million individuals have asthma. 30 million asthmatics are estimated to be living in India, accounting for 13% of global burden and contributing to 42% of global asthma mortality. Around two-thirds of asthma are left undiagnosed in India. So this is something probably known to most of us. The trigger factor, there is a trigger factor leading to airway inflammation, which then leads to hypersecretion of mucus, airway wall constriction, and swelling of the bronchial membranes, and therefore narrowing of the breathing passages, and that leads to the typical symptoms of wheezing, breathlessness, tightness of chest, etc. And we understand that there is an immune process behind all this. And essentially, it's an increased Th2 expression leading to a cascade of inflammatory mediators such as IL-4, IL-13, IgE, mast cells, and many others. And typically, this is a narrow airway, a normal airway, which in an asthmatic looks like this. So there is narrowing. And during an attack or an exacerbation, this is what it looks like. So these are, of course, schematic diagrams. So I'll illustrate my talk by referring to some of our cases. The first case is a 22-year-old male who presented with breathlessness and dry cough more at night and early morning since last 2 weeks. He also complained of chest tightness and wheezing for same duration. The symptoms were known to have worsened on exposure to dust and smoke, and he experienced similar symptoms last winter. His mother is an asthmatic. On examination, there were only polyphonic expiratory V's on auscultation. The X-ray was normal. The basic lab work only showed eosinophilia. And this is a lung function test which we did. And very typically, it showed a decrease in FEV1, that is the amount of volume of air that we force out during first second, during a forced expiratory maneuver. And there was a increase of more 12% or more and 200 ml or more after giving bronchodilators. We usually give 2 to 4 puffs of a salbutamol inhaler. So respiratory symptoms, which are typical of asthma, are well known. So especially in adults, they may varied symptoms. Symptoms are often worse at night and early morning, vary over time and with intensity. And symptoms may be triggered by varieties of things, including viral infections, pollution, exercise, allergen exposure, etc. Isolated features such as isolated cough, chronic production of sputum, shortness of breath, associated with dizziness or lightheadedness, chest pain, exercise-induced breathlessness with noisy inspiration may not be asthma. So every breathless patient is not running asthma. So this is the algorithm we follow when we are faced with a patient like this. So get the patient with these symptoms, typical symptoms, detailed history examination of the patient. If patient is already we ask, is he on medication? This patient wasn't. So we switched to another part of the algorithm where we decide to start medication. So history of variable symptoms, we have referred to this before, and this is true for children older than 6 years of age. And as we keep saying that symptoms vary in intensity over time. So there are seasonal variations, for instance, or day or night variations, or year-to-year variations, and there are obvious exacerbating factors. So how do we document that there is actually an airway obstruction? Wherever possible, we should have a pulmonary function test. The simplest scenario is like this patient. So we do a spirometry and we find that FEV1 is reduced and there is significant increase in FEV1 after bronchodilatation. So it's an open and shut case. The other variables are that there is that excessive variability may not be present on a PFT, uh, simple PFT, but if we do a peak flow meter readings at home over 2 weeks, there is significant variation between morning readings and night readings. And the other things which can help us diagnose are that there is a significant increase in lung functions after medication, anti-inflammatory medication such as corticosteroids, whether inhaled or oral in patients, or the significant decrease after exercise. This is particularly true with a lot of children, and bronchial provocation testing, etc., are more of a specialized thing. So when we face with a patient like this, we need to confirm the diagnosis. We need to concentrate on symptom control and modify any risk factors. And we need to look at any comorbidities. We need to look at inhaler techniques and adherence, and patient preferences are also important. So how do we treat these patients? There is a track 1 and a track 2. I'll talk mainly of track 1 as one of the methods. So if patient has very minimal occasional symptoms, okay, all they need is a low dose inhaled corticosteroid with formoterol combination as and when needed. If these symptoms are twice a month or more, then again a low dose ICS formoterol is good enough. However, these symptoms are there in most days, or patient is waking up at night for at least once a week or more, then we need to start regular low dose ICS, which is inhaled corticosteroid and formoterol, as a maintenance, and use SOS, the same medication, as a rescue medication. If the patient's symptoms are much more, then we need to give higher doses of the ICS, inhaled corticosteroid. That's the preferred choice. The other choice is we use a bronchodilator and long-acting and inhaled steroid as the mainstay treatment, and SOS, short-acting bronchodilator. And what is low dose, high dose? So most common corticosteroid use is budesonide, and 200 to 400 microgram a day is low dose, 400 to 800 is medium dose, and anything more than 800 microgram per day is high dose. Coming to a second case, this is a 32-year-old lady presented with breathlessness, chest tightness, wheezing for last 6 weeks. She also had complaints of dry cough since past 3 weeks, which worsens at night. Experienced similar symptoms while going to in her school years, which resolved by the time she turned teenage. Symptoms worsen at night in winters and on exposure to dusty environment, is what the patient told us. However, there was no family history of asthma. She was already taking formoterol budesonide inhaler, but on SOS basis as prescribed by a family physician, and had also given had a history of short course of oral corticosteroid once each year for past 3 years. Excess was normal, and basic lab work showed a high increased IgE and increased eosinophil counts. We come to the same algorithm. So we have a patient examination, then we ask a question: is the patient on regular medicine? Controller being inhaled corticosteroid. In this case, the answer is yes. So we follow a different pathway. And then we look at how do we go about confirming a diagnosis when patient is already on medication. A naive patient, no bronchodilator, easy to do a PFT. The patient is already on medication, then it may be a little difficult to figure out how to show the reversibility. So there are various things we look at. One is, of course, we still do a lung function and find a reversibility. So our job becomes easy. If the patient has very few symptoms, we can actually decrease the medication dose and then do a lung function in a few weeks' time to see if there is a reversible airway obstruction. However, if patient has persistent breathlessness, we cannot do that. We should actually upgrade the bronchodilators, the medication, inhaled corticosteroids, etc., and see in a few weeks' time whether it shows significant improvement. Any of these will indicate that patient has a variable airway obstruction. So in the patient we just spoke of, this is an example of pre and post 4 weeks apart on control of medication. This is FEV1, which was less than 800 ml, and after 4 weeks of proper medication, this literally doubled. So there was a significant improvement in clinical symptoms as well as objectively on a pulmonary function test. Once we have started the medication, then we need to constantly fine tune it. And this is the chakra we need to look at. So we need to reassess the patient on each visit, adjust the medication as required, review again, and this can be a constant process. So asthma is not necessarily a fixed thing. So it can go up and down at varying uh, and we may need to adjust. And there are various steps. These are based on GINA guidelines. And the initial first steps, if you follow the track one I mentioned, ICS and formoterol combination, is to use SOS only as and when needed. The next step is, if the patient has more regular symptoms, is to give a maintenance, low dose maintenance. In step four is high dose, medium dose maintenance. In step five, high dose inhaled corticosteroid and add a anticholinergic drug as an additional drug. So that is the way we need to step up or step down. Once the patient is better, we can consider after several weeks or maybe a couple of months to step down as well. We should not prescribe something and forget, and forever the patient is on the same medication. So how do we assess, is the patient well controlled? This is a simple test, asthma symptom control test. We ask for 4 questions. Is the daytime asthma symptoms more than twice a week? Any night awakening due to asthma? Short-acting bronchodilator needed for more than twice a week? Any activity limitation during asthma? Just 4 questions. And we ask yes and no. So if there is none of them, all the answers are no, then the asthma is well controlled. If it is 1 to 2, the score, then it is partially controlled. And if it is completely uncontrolled, if the score is 3 to 4. So if these scores are higher, we need to upgrade our treatment. If this score is well controlled for a significant period of time, we can consider downgrading some of the medications. So why poor medication adherence is a big problem in asthma? Patients just don't take treatment. As soon as they get well, they stop. There are various reasons. The regime itself may be difficult. We give too many inhalers and too many medications, so they get confused and eventually stop taking or take less. Or there may be genuine difficulties. An elderly person with an arthritis may find it difficult even to press an inhaler. Then there may be unintentional poor adherence. Somebody who is not very literate or may not have even understood our instructions, or simply an elderly person who has forgetfulness, or a very busy routine. Cost could be also a significant issue. And then there are intentional poor adherence, such as what will others say? What will other family members say? So not take the inhaler, or that I will get addicted to the inhaler, so not take the inhaler, etc. And how do we address this? On each visit, one of the factors we need to see in these patients is how well they're adhering to treatment. So ask the patient, in last 4 weeks, how many days a week have you been taking medications, all the medications or no medications or half medications? We'll know fairly how well the patient is this thing. We can also take help of some of the family members to know the reality. Then we can look at the number of each inhaler has a dose counter. So if somebody bought an inhaler which has 120 doses and is coming after 6 months and has never bought a second one, we know for sure that patient has not been adherent. So these are some of the ways to figure this out, and this is a very important area to be addressed. And we need to check with the patient how they're using the inhaler. Very important. You may think this is trivial, but this is the most important thing in success of the patient, the inhaler technique. Confirm in case patient is not getting better, we need to relook at our diagnosis. If there are other risk factors, we need to assess. Risk factors could be somebody is on beta blocker recently as introduced, or NSAIDs, or is still smoking, or there is significant allergen exposures, then we need to sort out or get rid of these factors, and also assess and manage comorbidities. Most common comorbidities are rhinitis, sinusitis, obesity, GERD, obstructive sleep apnea. All of these actually cause worsening of the disease, and so if we address them, asthma can be controlled better. And accordingly, treatment can be stepped up. And if the patient is not well controlled, we need to refer to a specialist or a severe asthma clinic. Coming to case 3. So this is a child, a 10-year-old, who presented with wheezing, breathlessness, easy fatigue, and cough since 2 months. His symptoms were worse at night time and also worsening in spring and winters. The family history of asthma, the father having the same disease. On lab workup, X-rays were normal. There was increase in eosinophil counts. And again, we come to the same algorithm. So symptoms, then detailed history examination, then we ask, is the patient on medication? And in this case, patient wasn't on medication. So we switch to the next thing. First of all, how do we confirm the diagnosis? Besides detailed history and examination, we need to look at do a pulmonary function test, and children as low as 4 year old can in a hands of a good uh, experienced technician can do a spirometry, and which is the most common pulmonary function test available. And we can look for change in the lung functions. It's slightly different for children. For children, an increase in FEV1 more than 12% is good enough. You don't need that 200 ml criteria that is seen in adults. And daily average peak expiratory flow rate variability has to be more than 13%, unlike the adults where it is 10%. Then a fall in FEV1 of greater than 12% is uh, is also can be relevant. So this is for instance, after an exercise challenge, uh, positive bronchial challenge test can be done in specialized centers. Excessive variation in lung function between visits is also a good marker. And again, we look for more than 12% change, etc. in the or the variability in the peak flow between the visits, and this also confirms the diagnosis. In this child, we did a lung function, and we can see a severe decrease in FEV1 and a significant increase, 70% increase post bronchodilator. This was a huge change. You can see the graph. And then how do we start the treatment? Again, the treatment is in stepwise, and this is how it goes. So the initial very mild disease, only occasional symptoms would be low dose ICS to be taken whenever a bronchodilator is taken. Otherwise, no. Step 2 is when symptoms are twice a month or more, then daily low dose inhaled corticosteroid dose is ICS ranges for this is different, and we'll look at the ranges that is for children, the ICS dose, the inhaled corticosteroid dose. Step 3 is where we get ICS and long-acting bronchodilator, such as formoterol. Step 4 is we need a higher dose of inhaled corticosteroid. The important thing is in children, there is an introduction of a leukotriene antagonist such as montelukast very early on in the steps, and except for step 1, every step there is a scope for using leukotriene antagonist. And just like adults, we need to go through this cycle. Each visit, reassess, adjust medication as necessary, review next time. And we as the patient gets controlled, we need to go down. As the patient shows poor control, we need to go up. And the basic steps are same: confirm the diagnosis, symptom control, modify risk factors, look at comorbidities. Even children can be obese, for instance, or inhaled technique adherence, and the child and the parent need to be discussed, need to be spoken to regarding their preferences. And there are various steps. So minimal symptoms, just take ICS whenever short-acting bronchiolitis like salbutamol are taken. Uh, Symptoms more frequent, we need to give daily low dose inhaled corticosteroid plus as needed salbutamol like short-acting bronchodilators. For higher level of symptoms, we need low dose or medium dose of corticosteroids along with long-acting bronchodilators. And the dosing are like this. For budesonide, 100 to 200 is small dose, medium dose is 200 to 400, and more than 400 is high dose. So we need to remember. And of course, for a nebulized thing, the amount to be given is much more because actually absorbed is much less. So 100 to 200 is actually 250 to 500 in the same dosing range. And for asthma control for children between 6 and 11, we need to ask about night symptoms. Do they cough? Do they wake up? Are they tired during the daytime? Are there reflux symptoms? How often they're using relievers? Are they playing with their children of their same age? Are they as active as the rest of the children? There is a change. They could do a lot of running around and now they're not able to run around. These are important things to ask. And again, we can formally go through these 4 steps and decide whether the patient is well controlled, partly controlled, or uncontrolled, and accordingly step up or step down the treatment. The differential diagnosis that we need to look at is chronic upper airway cough syndrome, inhaled foreign body, bronchiectasis, ciliary dyskinesia, congenital heart disease, bronchopulmonary dysplasia, and cystic fibrosis. Now, whenever it's not very clear whether this is asthma, then we need to consult a pulmonologist or a pediatrician who has specific interest in pulmonology. And coming to poor medication adherence, this is very similar to that in adults. And the same steps, similarly, we need to assess on each visit what is the adherence to the treatment and reinforce the need to take regular medication. And the steps to be followed are same: recheck how the patient is taking the inhaler or the parent is giving the inhaler, confirm the diagnosis in case patient is not getting better, assess and manage comorbid conditions and remove potential risk factors, consider treatment step up or step down. And if the patient is not getting better, then uh, send to a specialist clinic. Coming to case 4, this is a 63-year-old lady with 40 asthmatic since 40 years with increasing breathlessness, wheezing, dry cough since past 2 months. She was all right on asthma controller till last year, but this year had a ER visit, emergency room, and twice she needed short course of oral corticosteroids. She also had complaints of occasional brown mucus plugs being coughed out since last 2 months. The X-rays showed some bronchiectasis with finger and glove sign. We'll show you some images. The spirometry showed reversible airway obstruction. There was eosinophilia. The IgE levels were raised, and specific IgG and IgE against Aspergillus fumigators were also significantly raised. And this patient was uh, fulfilling the modified Isham criteria for diagnosing allergic bronchopulmonary aspergillosis. So these are the criteria, standard criteria, which is now followed all over the world. And this was the X-ray. We had these pluggings of the airways. So they were central, and there were these kind of shadows as if something was stuck in the airways. A CT scan of the same patient shows significant amount of bronchiectasis and areas where the airways, especially the dilated one, were plugged with high intensity, with uh, high density material, which kind of look as if they were a contrast on the scene. So the treatment of asthma remains same. We follow the same steps for control of asthma. And as far as ABPA, allergic bronchopulmonary aspergillosis, which is seen in a significant amount of asthmatics, especially those with moderate to severe disease, the primary treatment is corticosteroids and plus minus antifungal agents. And there are standard guidelines of how to go to proceed, but this is more in the domain of a pulmonologist. So such a patient where this is ABPA suspected should be referred to a pulmonologist who are handling such cases on a regular basis. Case 5, a 68-year-old gentleman, asthmatic since 35 years, on regular control of medication, presented with increased breathing difficulty, wheezing, and dry cough since past 3 months. He's using salbutamol inhaler for more than once a day since past 4 weeks and taking 4 milligram prednisolone since the same time. He received oral corticosteroids 3 times in past 6 months, had 2 emergency room visits and 1 admission in high dependency unit within last 1 year. A chest X-ray was unremarkable. Spirometry showed obstructive airway disease with no reversibility. Labs showed no eosinophilia. IgE, however, yes, lab showed eosinophilia and raised IgE. So we looked at this chart, and this is a busy slide. So basically looking at various biologicals which are available now for difficult to control, or patients who are requiring repeated admissions, or patients requiring corticosteroids repeatedly or regularly to control. So this is a flow chart of various uh, mediators which are released by the inflammatory cells in the body, and accordingly there are many biologicals available. In India, we have omalizumab, we have benralizumab, and we have one more should be there somewhere, mepolizumab also. These are the three available as of now to take care of such patients. And again, this is in the domain of a specialist, but we should be aware so that such patients who are poorly controlled are referred to a pulmonologist for taking care. This is a chart I would this a table looking at the various biologicals and their route for medications, how they're done, etc. In this patient, we looked at the table. This is a table to give omalizumab. He had high IgE, and based on the weight and the Ig levels, we decided how much omalizumab to give. And the patient was initiated on monthly omalizumab injections. And we found that this is after 6 months, there was not much change in FEV1. There was slight change, but not much change in the lung functions, because probably by the time he's come to us, the airways have got fixed as far as their restriction. However, there was a huge change in his quality of life. Patient no longer needed steroids. He had zero visits to emergency room since last 9 months after starting malizumab, and he's religiously comes every month to get his injection because that has made a big change to his life. Differential, we coming to differentials, we need to look in asthma patients, adolescents, and children between 6 and 11. We need to look at chronic. In children, we spoke about the various differentials. In adults, we need to look at inducible laryngeal obstruction, hyperventilation, dysfunctional breathing, COPD, asthma overlap, bronchiectasis, cardiac failure, medication related cough, such as ACE inhibitors, parenchymal lung disease, such as interstitial lung disease, pulmonary embolism, or central airway obstruction. A smoker presenting with cough, which is not clearly explained, could be because of a mass lesion sitting inside the airways. And of course, tuberculosis in all ages in India. Coming to case 6. So this is a 27-year-old female presenting with asthma, 20 years duration. Also had a lot of nasal obstruction, rhinorrhea, sneezing, hyposmia since 7 years with recent worsening. She was sleeping in semi-upright position with mouth open since last 2 weeks. She was already on formoterol, budesonide, inhaler, topical nasal corticosteroids, and azilastine, which is an antihistaminic, plus oxymetazoline. On physical examination, the nasal cavity revealed deviated nasal septum, bilateral pale edematous nasal mucosa, polyps and inferior terminates, and chest auscultation showed polyphonic V's. The investigation showed that there were absolute eosinophil counts were high, and so was IgE, very high. We look at the lung functions, and it showed airway obstruction with reversibility. And this is the decreased FEV1 and significant 14% increase. And this is the CT, this is the X-ray of the sinuses and the CT scan. The sinuses are completely choked with secretions. And she fulfilled the Isham criteria for ABPA. So these are the criteria. These are the things which made us make a diagnosis of ABPA. She was started on oral methylprednisolone. We also got the ENT to look at this patient. They did a FES surgery, and they found fungal debris in the sinus. And this was the histopathology, and you can see the fungal filament. So this patient turned out to have a combined allergic bronchopulmonary aspergillosis and allergic aspergillus sinusitis. This is a very rare disease and certainly a rare combination, both together, ABPA and AAS. So we started oral voriconazole along with the corticosteroids, and nasal symptoms improved significantly. As of last visit, patients was sleeping comfortably, wheezing and dyspnea had decreased, was much better. This is, of course, a rare case, so we just wanted to show you that rare things also happen. Sometimes we need to keep our eyes and ears open for it. So this is the same chart about various differentials. We'll skip this slide. So co-occurrence of allergic ABPA and AAS is usually infrequently picked up, partly because it's rare and partly because they present to the different specialties, ENT and pulmonologist. So we need to think of various rare conditions also occasionally, but overall asthma is very common, and we need to be able to diagnose asthma well in time and manage the patient adequately and keep modifying the medication as and when required, so that there is a good control of the disease symptoms as well as the inflammation which is going on in the lungs, so that the patient does not in the long time has a patient's morbidity is much less. Also, over a long period of time, patients on regular proper medication, anti-inflammatory medications, including inhaled corticosteroids, tend to have the airways which are still flexible and reversible and not turned like a fixed tubes which just don't budge despite bronchodilators. Thank you so much.
Thank you so much, sir, for giving out your valuable time and sharing your knowledge and making this session informative one, sir. I definitely think this session knowledge is going to help all the participants who have joined this session. Sir, I can see we have received some question from the participant. If you allow, with all your permission, shall we take these questions?
Yes, please.
Yes, sir. The first question is from Dr. Agarwal. He is asking, are there any promising emerging therapies or drugs in the pipeline for asthma treatment? And what are the potential benefits do they offer over existing options?
See, the mainstay of asthma per se remains inhaled corticosteroids and bronchodilators. So newer and newer bronchodilators are being already been are in the being used at present mostly for COPD, but we do use occasionally even in asthma. Those are ultra lava or ultra long bronchodilators, which can be given once a day, and potentially in future we may even get things which will work once a week. And as far as inflammation is concerned, as of now, the treatment remains inhaled corticosteroid. Uh, Different forms of corticosteroids are always being researched. Some of them are said to have be even less harmful, and I'm sure as time goes, they will further change further and become safer and safer, and it becomes easier to control. The big change in the pipeline is biologicals. So just like biologicals completely changed the field of rheumatology, I think they're going to make a big change to how we treat asthma. And it's possible that they may come now. As of now, we kind of use biologicals only for difficult cases of asthma which are not being controlled well. It's possible that with time, if biologicals become less expensive, more data emergence, and we may be using them in other patients as well gradually, only if data comes, and maybe regular medications will become need for regular medications might decrease significantly in a lot of patients because of biologicals, because we are basically figuring out the inflammatory cascade leading to asthma and changing or blocking some of those cascades to change the course of the disease.
Thank you so much, sir, for sharing your valuable insight on this question, sir. Moving forward, I can see another question on the asthma only that I can see it is from Dr. Snehali, and she is asking how was the adoption of telemedicine impact the management of asthma, and what are the challenges and opportunity associated with virtual care in context?
I think COVID taught us it was possible to treat patients virtually. So it has not replaced patient contact, but what has happened is that patients would come and show you, you will investigate, we'll put them on medications, and some of the follow-ups would take remotely through telemedicine, which made life easier for them. One could connect with them. So the things like assessing what is the your asthma control, whether you're taking your inhalers regularly or not, what is your compliance level, how are you taking the inhaler. All of this can be checked on telemedicine. Uh, the initial diagnosis or diagnosis using spirometry, etc., that requires a hospital visit or a clinic visit, and I think that's unlikely to change in near future.
Thank you so much, sir, for answering it really well, sir. Moving forward, I can see one last question for today's session, sir. Like the question is from Dr. Hanzala Imam, and he is asking, what are there any new technologies or strategies that can improve patient adherence to prescribed asthma medicines?
I think it's not far away when the inhalers would have a chip and they would be talking to the smartwatch, and which would be then connected, sending the data to a cloud. And possibly when we see these patients, we would be having that data in front of us, and that can help us fine tune the treatment. To give us simile, when we see patients with sleep apnea today, we always ask them to bring the compliance data, which is a chip in the machine, which is recording what's happening. The use is every day, or rather every night. And when that data is in front of us, we are able to counsel the patient better, sometimes readjust the pressures settings on the machines. I think something similar will happen with the inhalers being talking to the smart watches or Wi-Fi's, and kind of uploading the data on cloud. The other thing which can do something similar is peak flow meters, which would be also recording, and that data would be simultaneously put on the cloud. I can think of these two things which can help us ensure that the patient is doing well.
Thank you so much, sir, for answering all the questions and making this session informative one, sir. I
Yeah.
hope that doubts of all the participant has been clear, sir. As I can see, there is no more question from the participants, sir. With all your permission, shall we conclude this session for today?
Yes, please. So I'll
Okay, thank you.
thank you, everyone. I'll exit now.
Okay, thank you so much and hope to see you again in future also, sir, with different topics, sir. Till then, take care of
Yeah,
yourself, sir. We are closing.
sure. Yeah, thank you.